And great to see all the innovation that is happening around the world in terms of managing health and measuring health. There are the slides. Perfect. So what I want to do is take a step back. Alan was also talking about looking at the patient, the provider, and the health system level. And I want to look at how much do we know at the system level about health of population, how can we use data to manage population health. Before I go into this, maybe quickly as background for you to know where this is all coming from, I work with the Institute for Health Metrics and Evaluation, IHME, at the University of Washington. We are an independent research center, and independent is important. We don't provide any funding, we don't have member countries. We look at data and we publish what we find with the goal of improving health of populations around the world by providing better evidence on health. We're funded mainly by the Bill and Melinda Gates Foundation and the state of Washington. We're a group of about 190 people, faculty, researchers, staff, and trying to answer very key questions in health. What are the world's health problems? How well are we currently doing addressing these? And then how could we better spend resources on addressing these problems? In terms of managing population health, there's a few very important goals, and they've been alluded to this morning as well as yesterday in various presentations. We want to improve health outcomes. We want to control cost. We all know how limited resources are. We want to compare risk-adjusted outcomes and quality across providers and hospitals. And we want to identify high-risk patients and many, many more. But what we need to do to be able to do that is we need to measure first what are the health outcomes and risks that are currently affecting us. Then we can identify affordable interventions and basically target programs at populations or individuals. I'm going to spend most of my time today to talk about the measurement piece of this and how do we make sense of all these health data out there. The main approach that we have developed to measure health outcomes around the globe is called the global burden of disease. And it is, and I quote, a systematic scientific effort to quantify the comparative magnitude of health loss due to diseases, injuries, and risk factors. And I bolded the words that are really important. So we're measuring health loss. We're not looking at quality of life. We're not looking at cost and so on. Just in terms of functional health, how much is that impacted? We're looking at comparative magnitude. We want to compare across countries, across age groups, across different diseases, and be able to make decisions based on that. And it is a systematic effort in terms of using the same methods for all the different diseases to ensure this comparability, and it's scientific. All the methods that the data I'm presenting today are based on are published in peer-reviewed journals. The concept, global burden of disease, can be applied to very different populations. Administrative levels, I'll talk mostly about the globe and countries today, can be applied to counties at the subnational level, for example, in China and the United States, or the city of Paris has done a global burden of disease study, as well as to very other populations like General Motors for the employees of this organization. The latest version of GBD that's available on our website is GBD 2010 that was published in The Lancet in 2012. It was a complete revision, and the data I'm showing today is based on that study. So how do we measure the burden of disease? In a perfect scenario, and you see behind me here age across the x-axis and then health on the y-axis, you want to live a long life in perfect health. And then at one point, you die. So if you want to measure health outcomes, very important is what do people die from and counting the number of deaths. But then a death at age 5 is not the same as a death at age 80. So we're also looking at how long should a person dying have lived, and we count the number of years that we're losing with every death. And we call this years of life lost, another metric. And then you don't spend your entire life in perfect health. I wear glasses, my health is impacted to about 0.3%. If you suffer from chronic back pain, it's impacted to up to 30%, meaning 3 years with chronic back pain, we lose one life year equivalent, and we call this years lived with disability. And then if you combine YLLs and YLDs, you have DALYs, or disability-adjusted life years, the main currency we're using to measure burden of health, both from fatal and non-fatal health outcomes. We're going to publish the latest update of this study in the fall of this year, and we're currently covering 323 different diseases and injuries that affect health, 1,500 sequelae of these diseases, as well as 69 risk factors that cause or impact these diseases. We're covering 188 countries. We're going back to 1990. So a massive data set that is publicly available on our website, as well as in visualization. And a major innovation in this round is that we're moving to a very collaborative model, where we are working with over 1,000 experts in 100 countries that help us find data, vet the data we're using as input, look at the results, give us feedback on how plausible this all is, and we're working in their feedback to come up with the best estimates possible. Very briefly, where do we get all the data from for this analysis? Well, we're using anything from population-based data, like censuses, surveys, vital registration, global autopsy, and so on. We're using all encounter level data that we can get access to, hospital records, inpatient, outpatient claims data, as well as massive literature reviews on all the diseases we're covering for countries around the world, sensor data for air pollution, mortuary data for countries where there's no good vital registration, and so on and so forth. So it's a massive data synthesis effort trying to incorporate all the available evidence on health and then turn it into something that can be used for decision making. Maybe a quick mention of the Global Health Data Exchange. For GBD 2013, we're using about 35,000 data sets of the ilk that I just mentioned. And so to make it possible for others to find these data as well, we create this platform. You find it at ghdx.org, and you can search by topic, country, disease, and so on, and find data sets that might help you in research or for other projects. And it's a very usable and easy-to-use website. Once we have all these data for the analysis together, we go through an analytic exercise that I'm not going to go through in much detail, but I just wanted to show that we're using a very sophisticated set of methods, very complicated, but it's the same methods applied to every disease in every country. We're making this whole data system work. And then once we have analyzed the data, we communicate them to the different audiences, and we actually spend a lot of work, a lot of time thinking about who's going to use these data and what for, and then create the right formats. And it's actually there's a write-up called Communicating Data for Impact with our learnings from the global burden of disease and other efforts. The URL takes you straight to that paper. But basically, it gives a guideline as to how you can take data sets, especially massive ones like GBD, and then bring them to audiences that might be able to use them. But now to the meat of the analysis. I'm going to do a few demos of data visualizations that show the results of our work. And all the things that I show you today are also publicly available without registration on the website at healthdata.org. So I strongly encourage you to check those out and let us know via the contact form if you have any questions, suggestions, and so on and so forth. So let me jump into the visualizations. 1 second. So behind me, there should now be, yes, a beautiful big chart. So what you're looking at is basically the culmination of the GBD 2010 effort. And you're looking at the number of deaths around the globe back in 1990. And you see along the x-axis different age groups, 0 to 6 days, so newborn infants, to ages under 5, and then 5-year age groups all the way to 80 plus. And you also see on the y-axis the number of deaths broken down into 21 broad disease groups that range from, at the bottom, HIV/AIDS in dark yellow, dark blue nutritional deficiencies, the turquoise colors are cardiovascular diseases, the light one cancers, and so on. So you basically see that in 1990 we had about 10 million deaths in the first 4 columns, meaning in children under the age of 5. Very few deaths in the following ages, and then most deaths happening at age 80 plus, which is good because we want to live to age 80 plus. So if we now fast forward from 1990 to 2010, you see quite the difference. Let me just go back to show this in more detail. You see children's deaths shrinking and more deaths moving to older ages, which is great. It seems we have done a lot of things right in terms of reducing child mortality. But there's still a lot of work left in that area, because if we switch to YLLs, so this metric that counts the number of years we're losing with every death, you see that there's massive burden on the children's side, because every death at young ages contributes a lot more to overall burden. And then if we go to YLDs, so those are the diseases that ail but don't kill us, the back pain, the glasses, and so on. You see a very different pattern, right? They affect people at all ages, and less obviously in children. You also see very different diseases. You see in the light, very light green, neurological disorders, darker green mental disorders. The light purple is musculoskeletal, the back pain, and so on. And then in the dark purple, other non-communicable diseases like wearing glasses and the likes. And global burden of disease has made a big change, especially for mental and neurological disorders, really putting them on the map and quantifying the immense burden that these diseases cause. And then if we combine these two metrics, you get a very diverse pictures of disease and how they affect us at different ages. So I was showing the global view, as I said earlier. Since we are in Stockholm, let's look at Sweden, and you see that the pattern is very, very different. Very little burden at the children's ages, and then most of the burden in the older ages. So I'm going to switch to another tool now, which is called GBD Compare, and that's our flagship visualization that gets quite a lot of traffic and a lot of usage on our website, because it really allows you to drill from a very high degree of detail into the depths of GBD. What you're looking at right now is a square pie chart. And you see in blue non-communicable diseases, in red communicable diseases, and in green injuries. The size of the box is proportionate to the burden that these causes cause. And you see, for example, cardiovascular disease is a really big box, diarrhea, low respiratory infection, and others as another large box. Now you can drill into detail and break these boxes down. So cardiovascular is now breaking down into stroke and ischemic heart disease. You saw cancers divided into lung, liver, and other cancers, and so on and so forth. And so now you can actually get into the full details of the data. Since it's called GBD Compare, you should be able to compare some things besides just diseases. I'm pulling up a second chart here. At the bottom, you see a world map that shows the overall burden of all diseases in countries around the world, and you see that the red and yellow colors are the countries with the highest burden centered in sub-Saharan Africa. And now you can explore the interactivity of the things. So if you want to look at HIV, for example, you see the countries most affected are in what we call the HIV corridor along Western and Eastern and Southern Africa. If you look at malaria, you see the malaria corridor that basically goes across from West to Eastern Africa. But you can also look at diseases that affect more of the developed countries. And you see for ischemic heart disease, a lot of burden in the former Soviet Union. And if we want to check again Sweden as an example, you can also do it the other way around. And you look at Sweden and the profile of the disease. And you just saw the tree map change from the global to Sweden. And you see that the burden in Sweden is overwhelmingly non-communicable diseases and injuries, very little left in terms of communicable diseases. But you also see that lower neck and back pain is a very predominant disease in Sweden. So if you want to look at this around the world, you again, as you might expect, you see a lot more burden in developed countries compared to developing. So this is one way to kind of explore patterns around the world, different diseases in different geographies. And again, you can drill into any of the dimensions I mentioned earlier. You can look at different age groups, so the working ages and how burden is distributed here. You can look at differences between males and females and so on and so forth. So really a great opportunity to explore a lot of questions around disease and injuries around the world. I'm going to use the same tool now, but I'm going to take a slightly different tack because I was looking at just the diseases and the burden that they're called, but I mentioned that we also look at risk factors that affect these diseases. So here we're back with the tree map now for Sweden and the diseases that affect Swedes. So now I'm going to switch the display from just showing the diseases to showing risk factors and how they're attributable to the different diseases. Right now we're looking at alcohol use and which diseases it affects. And there's, as you might expect, colorectal cancer, alcohol disorders, but also breast cancer, as well as down here liver diseases, cirrhosis, and so on and so forth. And again, we have different opportunities to work with these data. There's a stack column bar chart. And this shows you all the risk factors we're evaluating and how they affect people in Sweden. So the leading risk factor here in Sweden, causing about 13% of total burden, is dietary. So eating too much of the wrong things causes about 13% of burden in Sweden. If we all ate the right things in Sweden, burden would be reduced by 13%. We also show how it breaks down into the different diseases affected, neoplasms, cardiovascular disease, and then diabetes. And then dietary is followed by high blood pressure, high body mass index, smoking, physical inactivity, high fasting, plasma glucose, blood sugar, and others. And again, you can explore those. Let's look at diet, since we just identified that as the leading cause, and we saw that it affects ischemic heart disease, stroke, different types of cancers. And we can explore in more detail what dietary risk actually affect us here. And that's low fruit, low nuts and seeds, high sodium, and so on and so forth. So again, you can drill down now into the different age groups, and if you want to tailor programs to women of reproductive age or to children, you can actually explore this in this visualization at great depth. I'm going to go back now and just give you a quick outlook on what's happening from here on out with the global burden of disease. There we go. Okay, so it's a massive data set, as I mentioned earlier. In the results that are available on the website, we have over 1 billion data points. And just quickly, why are those useful for any type of project, from political decision-making all the way to starting a company that wants to address health problems in different countries? We're synthesizing all the latest data on the diseases covered. We're using innovative methods. They're all peer-reviewed, published in journals. We're using consistent methods across all the different diseases and countries to make the results absolutely comparable. For every result we publish, every number I showed you today, there's an uncertainty bound that tells you how consistent are the data, how good are the underlying data. We're covering all causes at once, which is a really important differentiator. If you took all the studies that look at deaths from cardiovascular disease and cancers and diabetes, and you sum them all up, everybody would have to die 2 or 3 times over to make the numbers work. We make sure for every age group that every death is accounted for once in the GBD system. And then finally, it's fully imputed, so we have estimates for every country, even if the data are sparse. We're using covariates and other statistical methods to come up with estimates for these countries, because we believe that estimates based on little data are better than estimates than no estimates at all. So where are we going from here? I showed you the data at the country level. We are currently working with the UK, China, and Mexico to produce data at the province and district level. And we definitely don't want to do this for the US as well, funding pending. We want to attach disease expenditure to each one of these diseases to get an impression in terms of how much cost do these diseases cost, again, by country, age, and sex. And we're going to go into forecasts and say, given the current patterns and developments, and then assuming certain scenarios in terms of how the health systems develop, what is the world going to look like in 2030 or 2040 based on these diseases? So that is the end of my talk. Thank you very much for your attention. If you have any questions, I'll be here all day. Contact me on Twitter or email. I'd be happy to answer questions. Thank you.
Thank you so much. Thank you.
Thanks, Eva.
Thank you, Peter.
Thank you.